Hello everyone. Now our topic will be periodontal consideration for fixed prosthodontics. How is periodontium related to fixed prosthodontics? Basically, a periodontium of a patient and a fixed prosthodontic that he is going to receive are interrelated. The health of periodontium is totally based on the quality of the fixed prosthodontics that is going to come, the contour of the fixed prosthodontics, the tissue management that we have done to receive a fixed prosthodontics, the impression techniques that we have used, the margins that we have placed will decide the periodontium health of the patient. Coming to what are the different kinds of structures which are surrounding the tooth. The first is the gingiva, which is present just beneath the tooth. Now what is gingiva? It is the collar-like substance which is present all around. Now this gingiva can be supported one side with epithelial borders and it is further divided into different types. It is free gingival margin. Where is the free gingiva present? That is from the place the alveolar bone is not supported in the gingiva. That will be called as free gingiva. Whereas what is called the attached gingiva? The gingiva which is attached to that of that bone present beneath is called the attached gingiva. Now the margin between the free gingiva, we will have a diagram here. This is a free gingiva which is not supported by the alveolar bone. We'll have attached gingiva which is supported by the alveolar bone, and this margin is called the free gingival groove. Now for example, our cemento-enamel junction doesn't lie above the free gingiva. Our cemento-enamel junction lies below the free gingiva and where the epithelial attachment starts with. Now coming to the gingival sulcus, how deep is it? It is 1.8 in maximum patient and it varies to 0.6 mm in certain places based on the recession and the quality of the bone beneath. Because if more the bone is there, more will be the area of a free gingiva. If the bone is less, the free gingiva will be less. So the attached gingiva will be more and the free gingival groove will come into picture, which is in the deeper section. Coming to attached gingiva. Now attached gingiva, since it is attached, it will be firm, it has to be resilient, it is tightly bound to the underlying bone which is present, and the width of the attached gingiva based on the area, that is maxillary anteriors will have different, that of mandibular anteriors will have different, that of maxillary posteriors to that of mandibular posteriors. Now how is that variation taking place? So the variation is taking place because the bone in the maxillary anteriors to that of maxillary posterior is decreasing. So when the bone is decreasing from maxillary anterior to that of mandibular anteriors and that of maxillary posterior to that of mandibular posterior, the gingival width is also going to decrease and increase accordingly. The width of attached gingiva near about is said to be 2.04 to 2.86 starting from the variation of maxillary anteriors to that of mandibular posteriors. See, we can see in a clinical picture that this is the marginal gingiva. We have the attached gingiva. The marginal gingiva to differentiate clinically is always little paler in color rather than the attached gingiva, which will be red in color. And there will be this line of distinguishing, that is a free gingival groove, or also mentioned here as mucogingival junction. That particular groove will be present and you can distinguish the attached gingiva and that of the alveolar mucosa which is present. Coming to periodontial ligament. Now what is a periodontial ligament? Now periodontial ligament is present from that of the tooth to that of the free gingiva. Now width, it is widest at that of the margin and apex and narrowest in the middle thirds. Now this periodontal ligaments are also classified, we know, and different types of fibers are present: oblique, round, circular, or it can be the radial fibers. Now there can be 0.25 to plus or minus of 0.1 variation in the width of the periodontal ligament. Coming to know what is exactly calculus, how is calculus coming to picture, what is acquired pellicle, what is materia alba, how is actually a periodontal disease coming into picture. What are the different periodontal disease coming? Gingivitis, reversible or irreversible? Gingivitis is reversible. Periodontitis, it is irreversible. So when it is periodontitis, that means the entire free gingiva is diseased and it has reached to the alveolar bone. So what is a calculus? A dental calculus is a chalky or a dark deposit attached to the tooth structure. Now it is essentially a microbial plaque that has to be undergone mineralization in this area. So this is calculus. because it has got mineralization. Whereas an acquired pellicle is a starting, it is a thin browny structure which is coming over because of our saliva, our mucin, our food particles developing in the tooth, which can be cleaned and it gives stains. So that is most probably found in the smokers in the lingual sections of anterior teeth. We can see here a stain of brown. This is called the acquired pellicle. Now what is materia alba? Name itself is saying materia alba, something which has an alba. Alba is what? Now alba is a microorganism which is dead epithelial cells. Now those dead epithelial cells get accumulated in particular place where they are inviting the leukocyte to come into picture. Now leukocyte and these dead epithelial cells together, they adhere to the tooth and it is removed by water spray. So if your brushing technique and your rinsing of the mouth is proper, your materia alba removes by itself. Whereas acquired pellicle requires the help of a dentist if it is too much into place, and a calculus, of course, it requires a scaling and deep scaling at times. Coming to occlusal traumatism, a very big and vague term. Occlusal traumatism or trauma from occlusion. There is a difference in both the things. Occlusal traumatism, when your occlusion itself is not proper and it is creating some amount of disturbance in the masticatory forces. For example, we have some high points in our restoration or in our teeth. So what will happen? The force is directed in that particular section, that particular cusp, and hence that is called occlusal traumatism. That is classified into two types, primary and secondary occlusal traumatism. We'll come to that. Other is trauma from occlusion. That is because of the occlusal anatomy and that of the less overjet overbite. What happens? The teeth continuously is traumatizing a periodontium. That is called trauma from occlusion. We have different tests to find out the trauma from occlusion, that we keep our finger onto the index finger onto that of the marginal ridge, marginal gingiva, and we ask the patient to bite. So once the patient bites and we feel any kind of vibration, that means the patient is undergoing trauma from occlusion. Severely, we will see resorption of the gingiva in the lower mandibular anterior region. I was talking about occlusal traumatism, that is classified into two types, primary occlusal traumatism and secondary occlusal traumatism. Primary occlusal traumatism happens when the occlusion is not proper and the periodontium beneath it or the bone is strong enough. What is happening is the occlusion is not proper, so it is giving unwanted force onto the healthy periodontium and then making it weaker or diseased. Whereas in a secondary occlusal traumatism, our occlusion is proper, but the periodontium and the alveolar bone beneath is diseased. So when a normal occlusion coming and hitting, again the same, it is getting divorced, it is getting deteriorated, but the classification is differing. So primary occlusal traumatism when the occlusion itself is not good. Secondary occlusal traumatism when the periodontium and the other tooth structures are not great. Coming to periodontal pocket. We all do have periodontal pockets, but which periodontal pocket should be concerning to us? Now this periodontal pocket, why is it formed? Because we know the free gingival margin, we saw the free gingival margin doesn't have any attachment with that of the bone or the tooth structure per se. So this particular section is called the pocket. It is forming a pocket. Now this gingival sulcus which is forming the pocket, if it deepens more than 4 mm, that is concerning to us. Otherwise, we all do have gingival sulcus and gingival pocket which is healthy. Why is that healthy? Because to accumulate the food particles to get removed from there. Placement of the margin of restorations. Now very important section here is periodontium is going to get affected with the restoration. Now the basic and the most important motto is to understand that which kind of margin is going to give which kind of detrimental effect to that of our periodontium. Now if there is a supragingival margin placed, like for example in the lower molars or upper molars per se, any posterior teeth, is that going to affect anywhere in the periodontium or the alveolar bone? No, it is not going to do until it has anything to do where it is coming in contact with that of the periodontium or the alveolar bone. Now a supragingival margin which is placed high above the gingival margin, only if it is not adhering properly with that of the restoration and the tooth tightly, where the saliva can get into it, where the material alba can get into it. Until that position, everything else is healthy. Once that starts, it's failure of your crown or a fixed partial denture. So what is more concerning to us is thus not supragingival, it is a subgingival margin. In a subgingival margin, what are the things that we need to see? That is the intraclavicular margin placement. Now, intraclavicular, that means inside the crevice of the gingival sulcus. Now, inside the crevice of gingival sulcus, till the epithelial attachment, if you go ahead, it is fine. How much is the distance that you are not supposed to touch when you are doing a subgingival margin placement? That is, from the bone crest height. If you see the diagram, from the bone crest height, 2 mm of distance should be the maximum distance till you enter the clavicular area of the gingival sulcus to place a subgingival margin. Nothing more and beyond 2 mm, because once you go beyond 2 mm, what are we violating is the biological width of that particular area. So intraclavicular depth concerning should be not more than 2 mm, because the biological width is 2.04 mm. So till 2 mm our tooth and our alveolar bone will be supported. Once you determine to go beyond that, the alveolar bone will start recessing. Hence, what will happen? The free gingival margin will be more. It will also start recessing. There will be unwanted creation of the periodontal pocket and also accumulation of the food particles. Avoid the gingival third. This is a very important tip for a tooth preparation and also placement of a margin, that once the gingival third is reached, do not go beyond that. How will we understand that we have reached gingival third? We saw in a clinical picture, we can distinguish between the free gingival margin and that of attached gingiva or the marginal gingiva, that is a mucosal attached mucosa. So the color difference is very much clear. So once we are reaching till the first third of the gingival margin, which is pale, end your preparation down there so that you will not hamper with the biological width of the particular patient. Once this will not happen and you go beyond the free gingival margin and you replace your restoration towards the bone will start receding wheresoever it is, and whatsoever quality of bone, maybe cortical or complex or porous, it is going to reside because you have hampered the biological or the gingival third, you have entered the restoration. Coming to atraumatic preparation. Not only atraumatic preparation, here's the one more thing which is added to the new textbooks of Bouchers as well as the new textbooks of Schellenberg. It says that it is a traumatic impression technique. That is, while you're preparing your burr, your torpedo, your diamond should not be touching the periodontium. 1. It should not touch the gingiva. 2. Also, while you're making an impression, make sure you're doing a tissue management properly. You're placing your cord packer properly so that the gingiva swells up. It gives us a space for the impression material to get inside and make the impression of the subgingival margin that we have created. So in that way, what will happen? Because generally the free gingiva is also attached to the tooth. So once we are making the margin and we want to make the impression to find out that margin onto the impression, we will put extra pressure in that area. While we are putting extra pressure, and due to the viscoelastic property, as we all know, of impression material, we have to take out the impression materials in one snap. So once we are taking out in one snap, due to tensile force which is acting, it may hamper and traumatize our gingiva. So that is the reason not only a traumatic preparation but also a traumatic impression technique is important to be advocated to preserve our periodontium. So this is what is said, gingival retraction for impression making. That is what we spoke about. We have to use cord packer. And if you do not have a cord packer for that time, you need to advocate certain different techniques to do the gingival retraction. What are the different techniques that we can do? Gingival retraction is when we can apply local anesthesia we can apply some 8% of racemic adrenaline in those areas, or nothing to be done, we can just blow air, keep it dry and make the impression by not keeping it dry in that particular section. Tissue health as such is also important for us to mark that the gingival health and the periodontium health is all proper. Now, how will we understand we are not compromising the tissue health? The tissue health will be compromised when we see the color, texture of the tissue in that particular section. So the rationale for a tissue dilatation doesn't originate with exposing gingival margin, since the health of the gingival tissue is crucial for our success. Acceptable healthy gingival tissue is essential, as we have inflamed redundant tissue is liable in tissue dilatation. Also, after impression making, the tissue should be supported appropriately treatment restoration on a newly prepared teeth. That is, we are supposed to give a temporary crowns. The tissue shrinkage may occur after gingival margin placement or from irritation caused by the temporary restorations as well. And when will that get healed? That will get healed after a certain period of time, that is after placement of permanent restoration. So what are the different ways of tissue dilatation, which we'll be covering in a different lecture, but it is classified into mechanical, mechanico-chemical, surgical. We have different provisional restorations coming up. Now coming to embrasures. Embrasure plays a very important role. Why? As in, any embrasure present may be central incisors. The papilla which is coming over there, now when we are making an impression material has a property to get into a place wherever there is getting a place. Now that embrasure which is there, it is like an undercut for the impression material. So the impression material gets into that place, and when we start taking it out in a snap impression removal because of its viscoelastic property, what happens? We are hindering that particular embrasure area. What is happening next? The interdental papilla which was present is getting hurt over there. So the interdental papilla health is also compromised. In short, we are compromising again the mucosal and the gingival health present interdentally, because if we are not taking care of the embrasures which is there. So now how do we take care of the embrasures? Put certain amount of wax if there is a space present. Close those space before making an impression, and make sure your temporary and your permanent restoration which is coming should follow the crown as it was in the natural dentition, and not follow the total complete coverage of the embrasures. So biological width embrasures are the similar. We have Tarnow's principle here. What is Tarnow's principle? It says that from the width of the attached, that is the alveolar bone, to that of free gingival or the papilla, if it is more than 5 mm, it will not grow back. So we need to keep it less than 5 mm, so it can grow back to that particular section where the interdental papilla has receded back. Because everything is supported by the bone beneath. The bone more than 5 mm cannot give any support to the overlying mucosa, overlying papilla or gingiva present over there. So we need to take care of that. Of course, Ponticks plays a very important role in preservation of periodontium. Different Ponticks were advocated, but what was the reason that there were so many variations in the designs of Ponticks, starting from ridge lap to modified ridge lap to ovate Pontick to that of the saddle Ponticks? There were different Ponticks which came into picture, the fish overlap Pontick. These Ponticks were developed because the health of the periodontium beneath the Pontic area is also important. Now, if the Pontic doesn't have a convex surface, if it doesn't have a convex and have a concave C-shaped curvature, the food will go and accumulate there, and it will not be easy for that human being to clean the food from that particular place. Hence, what will happen? That particular food which is over there will cause the calculus grow with the health of the, it will hamper the health of the periodontium. So, it is very important to keep the convex surface both buccolingually as well as mesiodistally to make it self-cleansable in spite of whatever Pontic we are using. Second important thing is we need to always respect the tissue beneath the Pontic. So when we are having a metal ceramic restoration, now a metal is a stronger uh, it's a stronger material. So metal, when it will be in contact with the of gingiva, which is very soft, resilient, now that will cause all the time trauma to the gingiva. So it is always advocated that a thin layer of ceramic should always be there in the posterior or the back portion of the pontic of the area which is going to seat onto that of gingiva. Two advantage of that: a ceramic is more smoother than a metal, and second is that it makes it more self-cleansable and does not hurt the periodontium, the gingiva beneath that, and the mucosa is safe. Contours of restoration, yes, it first plays an important role. Now, if our contour of restoration is too much bulkier, the food particle will go and stuck in between, and the cleaning will not feasible. Now, cleaning is not feasible in interdental area. What will it lead to? It will lead to pocket. Periodontal pocket will deepen and it will be pathological. So, hence we are again compromising with the health of the periodontium. So, contour should be enough that how much it should be enough? That it should be contacting with the adjacent tooth in the contact area, in the ICP, intercontact position. The interdental contact position, as in the natural teeth, should be maintained in same with the restoration. So it is not that we are supposed to keep it open again. That is another wrong. Then what will happen? Again, we are creating space for all the organisms to accumulate and adhere over there. So what we are supposed to do, follow the natural anatomy. The crown should be following the natural anatomy of the teeth. The contours on the buccal as well as lingo side, mesial as well as distal side should follow a convex so that the food is self-cleansable and it should have a tight contact with the adjacent teeth. Coming to the occlusal surfaces. Now, how is the occlusal surface of that particular thing, of the particular restoration gonna be? Now, the occlusal surface of that particular restoration is also not supposed to have any kind of depressions that is deep enough to accumulate any particular organism. Now, if the occlusion in that has a high point, that is some place where that is contacting before and not allowing the other tooth to contact in its original last position. So what will happen? All the time that tooth is into contact first, and it will cause detrimental effect onto the abutment teeth as well as onto the ridge beneath and the mucosa. The mucosa will become reddish, it will become more red in color, inflamed, and hence also the abutment teeth which is there will be diseased, and the more pressure will fall onto that. It can lead to pain, removal of the crown, just because we have not found out if there is any high point in the occlusal surface. Also, the way of finding out occlusal surface high points is with the help of bull eye test. What is that? We use two kind of articulating papers, the blue and the red. Blue articulating paper marks all the contact point, and then you ask a feather-like touch to do on the red articulating paper. So when you do that, you will find all blue and red points in between. You are supposed to reduce only those red points. Those red points are marked as the eye appearance. What eye? There's a bull's eye appearance. Coming to the cementation, the most important and last but not the least kind of thing, it is cementation. That is the last procedure that we do, but it's of most important thing again. Any cement left after cementation around and beneath the crown which is placed is the most dangerous for the compromisation of the health of the periodontium. Now what is that happening? So any cement, may it be GIC, may it be composite resin cements or any other luting cement, are acidic in nature, which converts its acidity to basicity or towards neutralization in a period of over a day or at least 8 to 10 hours. Now 8 to 10 hours of time when the acidic luting agent is coming in contact with the gingiva, it is going to make the gingiva totally roughen out, and that will cause acidic effect on that of the periodontium and the gingiva. Hence, this will also start receding, and those particular small particles of gingiva where the cements are placed or left behind is gonna be very dangerous for further causing fenestrations of the restoration. The restoration and the tooth can totally be out because alveolar bone is gonna reside back. So we spoke about the gingival finish lines, which is also important for finding out which of the finish line can lead to compromisation of the periodontium health, of the periodontal health of the person.